ICU Patient-Centric Care in 2025. Treating patient is our privilege and ability. To satisfy them is our responsibility. The turmoil in the brain, we need to realize. Listen, listen, be gentle and always empathize.
And to understand more about this topic, I would like to call upon Dr. Mehul Solanki sir.
I request Dr. Dhiren Patel sir to introduce the speaker.
Dr. MEHUL Solanki is done internal medicine as a consultant critical care in BAPS Yogiji Maharaj Hospital, Ahmedabad, and his expertise in ICU management. The topic is way to improve satisfaction to a patient and family in ICU. Patient-centric approach in 2025. I think it's very important topic for all of us. Over to you.
Thank you for kind introduction, sir. And first of all, thanks to the Surat and Valsad Gujarat Criticon organizing team to me having here. And thanks all delegates who are here. So it is something like a comma in between the running session of academic. So it is more of toward the throat-provoking lecture. And over here might be our whole hall might not be agree on a one decision whether we should go with this family-centered care ICU or not. But yes, we can do some improvement in our care with that, with the permission of chair. Can I slide this? So way to improve satisfaction of patient and family in ICU, family-centered in ICU. So first, satisfaction. So સેટિસ્ફેક્શન તમારે સંતોષ આપવા માટે ગમે એ કરો, સામેવાળાને સંતોષ નથી, કાંઈ કરી શકવાના નથી. So whatever you will try your best, but if patient or patient relative don't want to be satisfied, they are not able to satisfied. So I would like to target your approach toward the giving the best experience during hospitalization. If you give a best experience to the hospitalization, that is equal to the good satisfaction of the patient and patient's relative. When the second word come in mind, that family-centered care ICU. So over here, after a lot of experience, everyone agree from their heart, yes, family should be there in the ICU. But on a next time, your mind, thought stopped you. No, I don't want this hassle. It would be create a more problem. More thing, more problem, more issues. When the relatives are there, they are trying to figure out, pinpoint out your problems, errors, issues, everything. So always, why? Because in our experience, we found and we heard lot of noises, news that there is a lot of raksak between the patient's relative, patients and the hospital staff. Sometimes even they assaulted the hospital staff and the doctors. And we always against it, we definitely endorse that no assaults. We do request the government to do best of best strategy and stringent rules to stop this assault against the doctor. But on the other side, how we can improve that gap between us and the patient and patient relative? How we can improve that trust between our hospital staff, patient and patient relative? So think that whatever you see, you believe it. So most of time patients' relatives sit out, they just listen whatever information is given to them by us or our hospital staff, and they believe that. If they found there is no matching, mismatching, or some kind of they thought that is not what we speak and what really is going on in the ICU, they having some trust issues, they having some kind of judgmental things that this hospital is not running well and all. So if you think that ICU patient, they are in a very pity, sad, painful condition, they are more on kind of dependent on others, that they need someone to be help them. And if you delayed for some time, they get angry, the relative get angry. And in that scenario, can you think that our staff or the ICU staff or the nurse staff is suffice to give a very quick response when they engage with something or someone? So why not to think that let's have some kind of a family-centric ICU, the family is allowed to be present more amount of time inside the ICU, and if they see all the things what we did, they start believing the trust improved, and that is the more core motto of the family center ICU. So family center ICU is an approach to the healthcare that is respectful of and responsible to the family's need and value. Key component, family present in ICU, family support, more communications. There is strong evidence as available, and that shows that family-centered ICU improve the medical goal achievement, patient and family experience satisfactions with care, delirium and psychological supports, patient and family psychological positive outcome. Even the cardiac critical care shares more and more recommendations for engaging family in the ICU in their routine care. American Heart Association state that engaging family in the cardiovascular care emphasize the importance of family engagement in this setting. And there is a ABCDEF bundle routinely is being used for prevention and treatment in the hospital. Over here, F, which is endorse the family engagement and empowerment of family in the ICU care. So what we think core principle of family-centered ICU is treating the family with respect and acknowledging their dignities. Information sharing is a key, providing an open and honest communication and complete information. Participations of the patients and patient family in the day-to-day care of the patient. Even there are some study and some recommendation, they are also allowed during the resuscitation, during the cardiac resuscitation, in a cardiac arrest scenario or some invasive procedure, if you can make such kind of policies or not. Collaborations, we do have a working together as a partner with the family and the hospital staff to take the decision and the plan of care. Benefit of family-centered ICU, it's improve the outcome, definitely enhance the patient's health outcome, family experience, reduce the stress. As most of family having a lot of stress, emotional, psychological distress, that will definitely reduce. Increase satisfactions, better decision making, because more they have trust you, more they take the good decisions with you. Do you have any guidelines? Yes, SCCM 2024 have endorsed the guidelines on family central ICU, and it's having a 17 recommendation with the 4 pillar. I will discuss the different 4 pillar over here. So family engagement, yes, liberal and flexible visiting hour. Like what our practice is, morning ma 1-2 kalak, sanje 1-2 kalak, then relatives are out, not allowed. But the guideline endorse, no. Either you do 2 things, allow the relative to be multiple time, frequent, like flexible, open, whenever they want to come or enter, they can come or go. But family means the first blood relation family. Pachi kaka ni, mama ni, fui ni, dikri, ye madwa ave ne madi le. That is not a family. Family means close family members. It's allowed. That is number 1. That is the open ICU or the flexible time. You can allow them કે તમે 2 કલાક સવારે આવો, 1 કલાક આવજો, પછી લંચ વખતે આવજો, બ્રેકફાસ્ટ વખતે આવજો, ડિનર વખતે આવજો, ફિઝિયોથેરાપી વખતે આવજો. If patient is mobilized, the relative asked to be stand next to it. ઘણી વખત કંઈક નાની મોટી કેર ચાલતી હોય, the relative asked to be there in a more of ICU time. So, and they are asked to join the clinical round, participate in day-to-day bedside care. Even they are asked to be present during the resuscitation. Or if your policy or the management or you don't accept this much of frequent entering or exit, even you can either collaborate a physical presence with the virtual presence of the family or family member. It's having a 2 benefit. If your patient's family or family members are very remote or distant from the hospital, they can have some kind of communications directly with the patient with some technology. It's been supplied by the hospital only. So that is also possible, like in the China or in a lot of places we found the robots are moving to solve something or to do things. So in the next few runs, the person start coming up that you can put one robot with the big screen, and from that robot, the patient relative directly can communicate with the patient. That could be the possible, and you can both together physical and the virtual presence of the patients and patients relative communication can be improved. Second pillar is family support needed. That address the education of family. We can do the emotional support for the family and the physical need. So education about the ICU care and the different procedure, we can make them understand so they can understand the better. Support of the family is very important because they are in a mental trauma. Sometimes we break the bad news to them and they are literally start burst in a cry. So that emotional support is very important by you or the hospital staff or the public relation officer also. You ensure the comfortable waiting in the resting zone of the patient's relative within the ICU. So third pillar is the communication support, and this cartoon provoked your thought that, sir, when I start talking, that is 20, 35, 6 relatives are gathered. Everyone not here to listen what I want to telling. Everyone is there to ask some question to show others that I am intellectual and I am having a lot of care about this patient. So this would be possible, but fine, we have to become above it. But our communication should be structured in a family meeting. There should be a multiple family meetings. If consultant is not free, with the other doctor of ICU or the hospital staff can do. You can provide a communication training to the clinician. Sometimes we feel that we know everything, but you know, sometimes we come in some kind of education lectures and we know that yes, communication, I am lacking with this part of communication. I am good with others, but if so, there is always remediations or improvement is always there if you focus on. So communication skill training is important. Use simulations training to build a communication and confidence for the patients, hospital staffs by giving the different scenario of it. The fourth pillar is supporting the clinicians. So structured program to help the clinician managing the family interactions. Once you start doing the meeting, the patient's relative is coming 10, 20 times, 30 times with the different questions. We are counseling the patient over here and patient's relative over here. The other person from relatives from there is starting, sir, I have one question. So there is a kind of strategy, or the other extra hospital staff or public relation officer, they can also communicate and then sorted out some non-medical issues, or our ICU registrar can give you a little more update or information about that. That can be possible. Support the clinicians to can deliver a higher quality and compassion care. America, where the lawsuit is very high, because we always feared that if someone take the photography or video and then viral it and go to the court, and what happen if you allow the family inside the ICU? But if you see the America start doing this practice. Family-centered ICU is started. So I quote this study of 39 American cardiac ICU, and you saw it, they having a 90% open visitation, and family support they gathered 85%. It's quite good. So it is nearly 100%. It is not only the cardiac care ICU, but also the general ICU also achieve the 77% of open visitation, and family round participation is something around 44%, wherein the cardiac ICU 77%. But in the future, I think the next study will achieve a more higher and better percentage of it. You can enroll the technology, as I mentioned, having some visual communication with the patient and patient's relative by the technology aspect. What is the barrier to this family care center ICU approach? The policy and leadership, lack of support by hospital administration, culture. Sometimes we ask that we can allow the patient's relative during the resuscitation or invasive procedures, but staff are very skeptical. No sir, why? फिर ये वो करेंगे ना. So some type of culture that is only been remediated by discussions and role models and some kind of policies or training. Resource limitation is always there. Staff shortage, material shortage, financial concerns are there. And commonly when I ask a family-centered ICU approach, the first thing which you click in your mind, and one question is always arise from the administration side. So, sir, what is our infection control policy? If you allow the family relatives come frequently inside the ICU, would not increase the infection rate in the ICU that we will see in the later slides. There is a physician-nurse interest is also variable. Time limitations are also there. There is also family ability is questionable. Family is in a distance unit. Family health literacy is also differ by patient. So to quote these infection related issues and other issues, if we allow a family centered ICU and thinks about the non-restricted visit time policy, then is do affect the different consequences of the ICU or not. So I just take out the one meta-analysis. Meta-analysis gathered around of 3,742 one patient are unrestricted visiting policies and one is with the restricted policies. What they emphasize on, they focus on ICU related infection in form of web, CAUTI, CRBSI. They also focus on mortality and ICU length stay as a quality criteria, and they also think about the research about the psychological aspect in the form of anxiety, depression, and the delirium. So this study is clear-cut showing that delirium, which favor the unrestricted visiting policies, means you allow the patient's relative for more frequent time. So that shows a favor the delirium part. Second thing, if you show the ICU-related acquired infection, not show any kind of gross difference between the two different groups. If you see the mortality, even no change in the mortality, same as length of stay, is favored toward the unrestricted visiting policies. And last, the psychological issues like anxiety and depression also favor the unrestricted visiting policies. Opportunity for improvement, yes, there would be there. We can communicating and we can gather more workshop for it. Challenging in Indian consent, what is there? We are kind of a family born person, and mostly the good or the bad decision or the complex decision always taken in the family. So that is the one thing. Organization barrier, high workloads, limited place can prevent the staff from fully engage with the family. Resource limitations would be, and lack of research, still there is no any that much research from the India is available for the family centered ICU. India's family are highly involved in a care decision. Yes, there is challengings are there, limited communication, rigid visit hours, lack of family space. Communication strategies in the Indian ICUs. We should be give a clear updates about the care goals, frequently physician and family meetings. Empathy and active listening must be core to interactions, implicate the structural communication algorithms. With that 4 points, you can understand that what routinely we do, we go to the relative, બધું સારું છે, કાલ કરતા સારું છે, તબિયત સારી છે, બીપીની દવા ચાલે છે, પેશન્ટ સારું થઈ જશે, ચિંતા ના કરતા, and then we went away. I'm not asking you to spend a lot more time which you are not able to spend, but yes, some amount of time should be there with the patient and patient's family. There should be kind of algorithm or chart or checklist that you should be informed that part to the patients and patient's relative that your status is this compared to yesterday or day before yesterday, you improve in this aspect, and the reports, today's report and the previous report is this, and this is our plan of action. So that type of communication definitely give a more inputs and trust bonding is improved. Family involvement and support in the recognition family decision making role, offer the emotional and spiritual information help, improve the ICU environment with the waiting area and caregiver comfort space if you involve the family in the ICU. Improving the visiting hours, flexible or the open visiting hours reduce the anxiety and improve the trust, encourage participation and emotional relief for the family, strong recommendation to relax restrictions, especially in the end of life care. If you think, still if you are not agree with me about the family care ICU, but if you think that in an end of life issue, are you allow the family to be go in a multiple and the liberal time or not? If the answer is this, yes, then why not in a other part? Because in an end of life issue, you presume that relative accept the consequences of the future that is not going to survive, and you accept it. So that kind of, your fear factor to be taken out to build a more and more trust and satisfactions with the patients and patients' relative. Yeah, how you implement this policy in your ICU. So first, go and meet with your management. Kind of mapping should be required, a blueprint should be required. Baseline assessment should be there, your staff, your resources is okay or not, are you able to do or not, in a what approach you can do. It's, I think, take a 1 or 3 months. Then you go with the trial run in a one ICU, that how it is run, how it is work. Then you can found some lacunae of it, and you try to fill the lacunae with the different trainings and different communication with your hospital and hospital staff. Then if you feel okay, that is one running model or the trial model is fine, then you try to implement in all of your ICU. That again take a long journey, and then you continue, and every time you reassess and remediate, and you can improve that care in the ward. So implement in the ICU. So conduct the staff training for empathy and communication is very important. Structured family meeting thrice weekly, regular feedback collections through the family center ICU. So key takeaway, prioritize family presence and structure communications, support clinicians through the training and debriefing, promote compassionate ICU care. Family center care must be viewed as a standard quality, not the option. So at the end of the lecture, I can share a few thoughts with you, or you can think about that what is wrong in asking the relative to be stay during your round, because that time you can more aware about the data or the vital data of the patient, the reports, so you not need to be remember if they ask randomly when you are not in front of the patient. That also shows the relative that this doctor is examining the patients in proper way, the communication of patients with the doctor is very good, so they are having a more trust. Ask the relative to be come in the ICU during the food hours, like patients, when patient is eating, then you can ask the patient's relative to come inside, so patient also get a good sympathy with the patients, and the food or the nutrition part can be improved. Even during the small care, like the physiotherapy, like the mobilization, like sometime walking, sometime turning, or in this daily care, you can even ask the relative to be there next to the patient. So even a small pain or small thing can be taken care by the patient's relative, give by the extra empathy for it. And if not, then you can start add few more hours in a visiting hours, specifically to the near dear relative, and try to expand. And yes, your communication with the patient, if you still feel that is good, but you have discussed with this with the other part of your colleagues, that how can I improve that? And I think that mix and match improve the trust and gain and communication with the patients, relative and doctor. Thank you, sir. I think rather than the question, there is a lot more comments from the audience which I am like to hear. What is your opinion about the, what you think about, is it possible? Yes, if it is possible, then what could be the footfall or what could be the hinge you can find, and how the society can help?
Family-centered ICUs are possible in India also, but see, in India, our nursing and patient ratio is very poor. So, sometime what happened, one staff is seeing 3 patients at a time, and she went for the shifting to the same patient, and that time patient relative came, and they see suddenly that monitor is not working, patient is lie down like weird in the bed. So that will create the problem more. If our staff patient ratio will improve, then definitely it will be the helpful. And in my opinion, if patient is sick, then definitely you should allow more frequently, because we are also giving more time to that patient, and better communication is the always best.
No. Good point. That is one of the point which is shown in the resource.
Mehul bhai, thank you for your talk.
Thank you, sir.
When I was listening to your talk, I thought this thing we are doing every day. What sir told, we can, if patient is going to be more critical or he will be more sick, till that time you have allowed the relative, and then you will tell that now your patient is sick, so you will be segregated for a while, you should come twice in a day, we will counsel, then they will more compassionate to you. પહેલા પેશન્ટ સારું હતું આવડે તો તમને ખરાબ થયું તો અમને સાહેબ કહે છે તો સાહેબ બહુ સારા છે અને ધીસ તમારું જે ટોક હતી ઇન tier 2, tier 3 city, this we are doing every day. In tier 4 city, relative, if you them kick them out, they will sit. એટલે તમે જો કાઢશો તો તમારી સાથે ઝઘડો કરશે કે અંદર અંદર રહેવું જ છે અમારે. એટલે ટાયર 3માં અત્યારે અમે આ પ્રેક્ટિસ ફોલો કરી રહ્યા છીએ. ફેમિલી બે વાર આવે, 3 વાર આવે, ફીડિંગ આપવાનો ટાઈમ હોય ત્યારે એ ફીડિંગ લઈને આવે. અને that we are showing improvement in patient care also. એને કારણે આપણા સ્ટાફ ઘણા અવેર રહે છે અને we are feeling this system is good.
Any more?
I 100% agree with Darshan bhai. Actually, we are following this pattern since start only. From start only, our ICU have one attendant all the time, 24 hours. And I actually, sometimes it help in reducing the nursing and patient ratio. કારણ કે સગા જ થોડું કામ નર્સનું પતાવી દે એટલે ઉલટાનો રેશિયો ઓછો થાય તો બી ચાલે. અને સેકન્ડ, વી ઓલવેઝ કીપ ધ વન પેશન્ટ ડ્યુરિંગ ધ પ્રોસિજર ઓલ્સો, ડ્યુરિંગ સેન્ટ્રલ લાઇન ઇન્સર્શન ઓર એનીથિંગ, વી કીપ વન રિલેટિવ ઇનસાઇડ. ઇવન ICD ઇન્સર્શન, ઇફ સમથિંગ હેપન, દે આર વિટનેસ કે વી આર ડુઈંગ એવરીથિંગ ઓન. પડદા પાછળ કંઈ થઈ જાય તો ઇટ ઇઝ વેરી ડિફિકલ્ટ ટુ એક્સપ્લેન કે શું કર્યું એમ, પેશન્ટ તો સારું હતું.
I think it is very thought-provoking subject. મેહુલ અને વેસ્ટર્ન વર્લ્ડ્સમાં તો ઇટ ઇઝ દે આર હાઈલી રિગ્યુલેટેડ. દેર આર સો મેની ડેટાઝ. પણ જે વિશાલે વાત કરી ઇઝ વેરી રિલેટિવ્સ. બોનસ ઇઝ રાઈટ કે અહીંયા આપણે આપણી ઈચ્છા હોય છે કે આપણે સગા નવા દઈએ, પણ વી આર હેવિંગ ફિયર કે આ બધું જોઈ જશે. આપણી જોડે સ્ટાફ રેશિયો ઓછો હોય છે. પ્લસ બીજું, વી હેવ સીન ઓપન ICUs વર્સિસ ક્લોઝ ICUs. ઓપન ICU દે હેવ અ હાઈ ઇન્ફેક્શન રેટ બિકોઝ so many patients ના રિલેટિવ આયા જ કરતા હોય છે, because we don't have a strict disinfection policy. So there are so many other things which is need to be improved. અને પછી આપણે વેસ્ટર્ન્સના જે ડેટા છે એને ફોલો કરી શકીએ. ડેફિનેટલી વી કેન involve relatives in the ICU.
Yes, truly agree, sir. But as meta-analysis shows, there is
yes,
reduction in the infection rate. We have an Indian scenario or Indian research to be needed.
I contradict. તમારા અંદર જવાથી ઇન્ફેક્શન રેટમાં એટલો ફેર નથી પડતો. ઓલ સ્ટડી ઇઝ સેઇંગ ધેટ ઇન જર્મની એન્ડ અમેરિકા ડોગ્સ આર અલાઉડ ઇન ICU. કારણ કે ત્યાં એના છોકરા નથી આવતા, છોકરા આવતા નથી. ડોગ્સ એન્ડ કેટ્સ આર દે અલાવિંગ ધેમ ઇન ICU and patient recovery improves with that.
Yes, I agree with Darshan. I was in Leicester. There, a patient.
It is not only the relatives coming. It is a disinfection policy. See,
No, I agree with Darshan.
I am putting focus on disinfection policy. કે આપણી એવી stringent policy હોતી જ નથી.
So to conclude, Mehul, I have seen even horses coming in the ICU because patient એ મગાયા છે. I was in Leicester. એને ઘોડા બોલાયા.
હવે કોઈ એલિફન્ટ ના કહેતા.
Thank you everyone.
No, I am witness to horses coming in the ICU. એટલે horse અંદર ના આવે પણ
Manoj, I think it's time. We are running late of time. Please,
So to conclude,
please conclude.
To conclude, active decision making with family is the time. We have to call them daily inside with whatever we can. Barriers are all mental. It's not physical. Let's break those barriers. એ અંદર રહેશે, he will see everything happening in happy times also. એવું નથી કે serious છે તો જ અંદર લાવો. So they will justify the care given, and we are coming close to such discussions with talks given in Gujarat Criticon. Thank you, Mehul.
Thank you, sir.
Thank you so much, Dr. Mehul Solanki, sir.